We have now administered 6,216 tests at Bryan Health in one form or another. Positives are now at 758, and we have a big number of pending right now, 731. So again, I'll be back up to share some information with you. John has some good information today as well.
Thanks, Bob. I first wanted to address the pending number. So that's probably the highest number you've heard of, 731 pending results. But I want you to know in the last 45 hours, we've administered 680 tests. And we have told people that typical turnaround's about 48 hours. So we should see a lot of those results coming back today. You know, I've talked about percent positive. So just to share with you, again, in our drive-through, about 12.5% of the people going through the drive-through are coming back positive. The people that present at the hospital in our emergency department, again, at 12.5%. People that are presenting at our urgent care, that is at a 9.4% positive rate. And people to where we go and utilize our mobile unit is at a 30% positive rate. Overall, if you take it all into account, we're at about a 13.8% positive rate for those that are being tested. We have 24 patients in-house that are COVID positive currently, 11 from Lancaster County, 13 from outside of our county. We have 4 individuals here pending results. We have 8 individuals on ventilators. 2 are from Lancaster County, 6 are from outside of our county. 9 of those individuals in the intensive care unit, 4 in our progressive care unit, and 11 in our general care unit. We did want to share with you, we told you that we would be taking our mobile unit to another location. We will be doing that on Friday, and it will be from 4 until 7 p.m. at Lincoln High School. And that is being arranged through the health department. So the health department has been in contact with people, and we've been really working through the cultural centers. So people are lined up to come during that period of time or scheduled during that period of time. So it isn't one of those where you can just call out to a number to schedule, because we still have those capabilities at our regular drive-through at LifePoint that people could take advantage of. So this will be designated for a specific group of individuals.
If you've been tracking or interested in the story on race, it's time to pull out your pencils and jot some things down until we send this out. So we've broken it down into a couple of different categories. We have Black or African American as one category, Asian, which obviously could be, you know, a lot of different nationalities, as another category. There's an other category that's a kind of a catch-all, then white or Caucasian, and then Hispanic. So for the Black or African American category, and these were results as of May 11th, so it's a few days behind, but there were 36 positives. For the Asian subset, there have been 122 positives, other 73, white 250, Hispanic 252, and at that time it got us to a total positive count of 733. I think this dovetails into John's mention about working with the cultural centers and getting to Lincoln High. For the percentage of tests given among all races so far by Bryan, Black or African Americans have received 4% of the tests we've administered, Asians 7%, other category was 6%. White or Caucasian, 70% of the test given, and the Hispanic population accounts for 13% of the tests we've administered. So if you're looking at percentage of test positive from those races, the African American community has accounted for 5% of our positives, the Asian community 17%, other 10%, white 34%, and Hispanic 34%. You take this one step further, and the positive test rates by race as of May 11th, Black or African American, 15% of those individuals were being confirmed positive after testing. Asian, it was 31%, other 20%. white or Caucasian 6%, and then 31% of the Hispanic population that we've tested has come back positive. So I hope that addresses some of the questions that I don't even remember who was asking that of us a while ago, but there were a couple of questions last week on that. Then the hot topic now seems to be testing and test validation and so forth. So the question was posed by at least 3 different members of the media on asking who our manufacturers were, what's the validation process we go through, and so forth. So I have some information for you. Our manufacturers that we're using, there's currently 2. John was referencing the Cepheid test yesterday. It's called the Cepheid, CEPHEID Gene Expert Test. And then the other one that manufacturer we're using is the Luminex Aries test. These kits are coming from the same manufacturer, so if that is what you're looking for. As far as validation, I believe Christy in her past reports, Dr. Ina Silenix and Dr. James Nora all referenced this in past briefings, but to just go over it again, we are accredited by the College of American Pathologists, or CAP, and they're kind of considered the gold standard for laboratories in the United States. Their requirements for validation are more stringent than those defined by CLIA, which I believe that's Clinical Lab Improvement Amendments or something. It's another accrediting body. So more stringent than that or the state of Nebraska. I brought this kind of prop. It is called the Common Checklist for the College of American Pathology program. And in it, you have all kinds of detail about what kind of processes to go through and so forth, and kind of the standards we're held to. I believe this is public. Anyone can go to the College of American Pathologists, members of the media, and take a look at that. And on page 43, there's some things in there about non-wave test and the validation and verification process on it on page 43. And that's where you're going to find the kind of category that COVID-19 falls under. There is a requirement to release the verification and validation studies. That's typically reserved for peer review publications upon patient request, but I think it would be available to the media. But what we would ask you to do is go through CAP and get the detailed questions about this, answered. And then if there's Bryan-specific things, either they'll release it to you or come back to us. It's really pretty readily available to us because to be accredited by CAP, you have to have this always up to date and ready to go. And frankly, it's a red flag if you aren't. So it's not going to be a great deal of extra work if you get your questions answered through CAP first. So tons of complexities around that, very stringent. I know that there are other testing mechanisms out there, and that might be the line of questioning coming from the media. Don't want to comment on any other process people are using, but this is what Bryan's doing, probably the gold standard for validation and verification, extraordinarily stringent.
Our percent of positives have been relatively the same. I think I reported last week or so about 12.5%. We seem to be in that same range. I think as the mobile unit continues to go out to areas that are kind of identified as hot spots, you will always see those percent positives come back a little higher. But I would say we're somewhat leveling off, and I made this comment to some others today. I think looking at just the number of positives is just one aspect of this. I think to talk about the severity, what we are monitoring more closely is how many patients are needing to be hospitalized and how many patients are needing to be on vents. Because you can watch the positives go up, but that could also just be a signal of the amount of testing that's now available of seeing it. So you're really looking at the severity of the illness of the individuals that are testing positive.
Yeah, we're excited about that. Of course, I was watering my lawn this morning, so I'm sure it'll rain today. I hope it doesn't bring down the cloud cover so it can't be seen, but I believe it's at 2:45. The Nebraska Air National Guard will be taking a low-flying track over Lincoln, going across St. E's, and they estimate the time at 2:45 for St. Elizabeth's, 2:45 for Bryan West as well, so I'm guessing it doesn't take that long to span that distance when you're when you're in a very fast plane. But we're excited about it. It's Hospital Week. I think it's a very fitting tribute. We're very grateful for it. We're publicizing it through our internal employee app, and I know that we plan to get out and take some pictures. So yeah, I mean, it's, again, we've said it many times, we are just so grateful for the support that healthcare workers are receiving at this point in time, both our clinical and our support staff. But I'd like everyone to think that this salute is not just for the teams at Bryan and St. E's, it's for all of us that have been dealing with this for months and months to come.
So we have had other businesses talk to us about coming specifically to their place of business to do some testing, and we're continuing to investigate that with those individual businesses. And we just think it's a great service to be able to offer to them. So I don't know if we'll publicly be talking about that because the businesses like to just keep that confidential. I just think they're being more proactive in relationship to testing, and it could be because if they have an individual test positive, they're just taking additional precautions. So we're really trying to just assist and get people what they need to have and give them access. I think you have seen that increase over the last few weeks, but as I mentioned before, it's somewhat controlled. A few weeks ago, we were averaging about 4 to 6 people on ventilators. I think now you're starting to see that be more of a 7 to 9 range. And in relationship to the peak, I really don't believe we've hit it yet. I think because we continue to flatten the curve, it'll probably be extended out even a little further. I think the latest modeling we had seen, and it's a little old right now, was about the 16th of May. I believe we'll probably be a little bit past that, but it's in a much more controlled environment.
I think it's a couple of things. There's been a language barrier that when such a growing percentage of our population is not English first as a language, I don't think we've done a great job as a state, frankly, getting the messages to different communities as effectively as we could early on about prevention aspects. There's been a lot of stuff nationally about socioeconomic status of how if there is it doesn't discriminate who gets it, but certainly you know, your living conditions and your access to health care and your access to information can be compromised, and I think that's a little sad, but probably a contributing factor. I'd say those are probably the two biggies, Matt. It's been the language barrier and then just the socioeconomic trends that you're seeing happening everywhere. It's very personal to us at Bryan. That's why we have instituted the drive-through before anybody else in the state did, and that's why we started the mobile clinic that John's been talking about, you know, for 4 weeks now. It's important to get to those parts of the community. They're valued members of our community and our state, and we owe it to them to try to improve on it.
We just have identified this language barrier and how we're trying to get more of the information out on the airways, Telemundo and some of those. We've worked with the health department on putting the flyers in multiple languages, and I think that's really important. And just access in general, and that's even before COVID. We've always talked about access to health care for individuals, and we want to make sure that we're giving them access in whatever way that we can. And I think we've identified that even more so with this type of virus, of getting information to people and getting them access to get tested, and then helping from the educational component, because as we've stated before, this isn't just about where they work, it's their living conditions. So we have to work more deeply with these individuals about how to appropriately separate and help them to social distance appropriately.